Peterson, 13th of the 1st, 85.
Okay, first of all, sir, I'd like to stand up, that's okay. Stand here and turn around, remove your trousers, that's alright. Okay, lovely. So ideally you want the patient standing, this is the best way to look for any varicose veins. So first of all, the obvious thing you're looking for, inspect your any varicosities. So you're looking for any sort of bulges in the veins. So if you look to where the veins normally go, that's the easiest way to do it. First of all, you look on the medial side, this is the long saphenous distribution, and looking for any obvious bulgings or varicosities there. So on either side here, I can see no long saphenous varicosities. Then look on the lateral side, and you can look for the short saphenous vein distribution, and again looking for any varicosities there. And again, this gentleman, there's no varicosities on either side. So once you've looked for any veins, next you want to look for things associated with varicose veins. So one of the most common things is venous eczema, and accompanied by this you'll also get hair loss. So you look for any sort of eczema around the lower part of the leg there, and there doesn't seem to be any eczema, and the hair is there on both legs. You'd also like to look for edema in these patients, because patients with poor venous flow will get quite a collection of fluid in their legs. And again, this gentleman, there seems to be no edema here at all. You're looking for a lipidodermatosclerosis, which is a hardening of the skin around the ankles. We get wider at the calf, thinning at the bottom. Hemosiderin deposition, and this is pigmentation around the calf here. Other things you want to look for, any ulcers. Venous ulcers tend to be around the gaiter area, which is on the medial side, over the medial malleolus, around here. And again, this gentleman doesn't have that. And finally, I'd like to look for any scars, which would be an idea that the gentleman had previous surgery. Just like to turn around for me, sir. To find the saphenofemoral junction, you find the pubic tubercle, and then from that you want to go 4 centimetres lateral and 4 centimetres below. So just find the pubic tubercle, approximately 4 centimetres across and 4 centimetres below. And then you're just inspecting here and you're feeling here for what's known as a saphenobarics. And this is basically quite a large varicosity of the saphenofemoral junction. And again, this gentleman doesn't appear to have one. So while you found the saphenofemoral junction, you want to perform the cough test. So in this, you place your finger on the saphenofemoral junction and you ask the patient to cough. You're then feeling for any thrills or obvious abnormalities in here. So just like to take a deep big cough from me, sir. Nothing coming in. No obvious thrills or anything abnormal there at all. So another thing you want to do while the patient's standing up is what's known as the tap test. So again, you find the saphenofemoral junction, pubic tubercle, 4 centimetres across, 4 centimetres below. Then you want to feel the varicosity veins that you've found. So for example, say the gentleman had varicosity along the saphenous area. I want to then tap on the SFJ, and if there is any imperforate valves, you should feel the percussion going down the leg. Obviously start up and then keep working your way down so you can no longer feel the percussion. This isn't a particularly accurate test, but some examiners might like you to do this. Okay, so the next part of the examination, you need the patient to lie down, and you want to do what's called the Trendelenburg test. So first you ask the patient to lie down, then you then get the affected leg and you raise it. So let's raise your leg, please, sir. When doing this, you're trying to get as much of the blood out of the leg as possible. Now ideally you want to do this for a long time, but obviously in your exam, quite short time. Then you want to place the tourniquet quite high up in the leg. Once you've done this, you ask the patient to stand up. You're looking to see if the varicose veins fill up again. If the varicose veins don't fill up again, and it did previously, it indicates that the problem is up in the SFJ junction. If they don't fill up, if they do fill up, it means the problem's actually lower down. And then you can then systematically work your way down doing this, try and pinpoint exactly where the problem is. So if you'd like to stand up for me. As you can see, there's no varicose veins, and you'd expect this gentleman's SFJ was competent anyway. So let's hop back onto the bed again. I'll just show you an example of the tourniquet test. So just releasing the tourniquet. Again, so like to raise your leg. This time we're looking for the mid-calf perforators. Get the blood out. This tourniquet on. Back stand again for me, sir. And again, this gentleman's mid-calf perforators seem to be okay, and there's no obvious varicose veins again. So you continue this, you do the popliteal, check the popliteal junction, and then check the mid-calf perforators as well. Okay, so back sit down again for me. Final test you want to do with a tourniquet is what's called perphase test. This test essentially is to check if the deep veins are working. For example, if someone had deep vein thrombosis, it wouldn't be working. This is the kind of test you do to make sure someone's adequate for theatre. So you can't then take out their superficial veins and then find they don't have any deep veins. So what you do is place the tourniquet on the leg, ask the patient to stand up, raise themselves onto their feet 10 times. And as you're doing this, you're looking to see if the superficial veins collapse. If they collapse, it indicates the blood is going to the deep system and there's no problem. If the superficial veins stay varicosity and full of blood, there might be a problem with the deep system. Okay, that's lovely, so sit down. Once you finish using the tourniquet, you then have to examine I'd like to use a Doppler, please. Check the saphenofemoral junction competency. In real life, I no longer really use a tourniquet, and it is all done with Dopplers. I'll show you now how to do it with a Doppler. So what we're going to do again is find the saphenofemoral junction, so you find the pubic tubercle, 4 cm across, 4 cm below. Get some jelly in your Doppler, place it on. And you're listening for the one whoosh as the blood goes up, and then if there's another whoosh, it indicates there's some saphenofemoral incompetence. That gentleman had just one whoosh. So here's a close-up of testing for saphenofemoral junction competence. So here the whoosh up. There's no whoosh down. Once more. No whoosh down. This gentleman obviously has a competent saphenofemoral junction. So now I'm going to do exactly the same, but in the popliteal junction. So again, you must have the patient either sitting down or not standing on that leg because you can't squeeze the calf. Place the Doppler, squeeze the calf. As you can actually hear in this patient, when you squeeze up you hear a whoosh, but you also hear a whoosh on the way down, indicating you may have some incompetency of this valve. So whoosh up, then whoosh down.